Happy New Year. It's a pleasure to be back in 2022 for the International Grand Rounds, Pan-American Trauma Society, University of Miami Grand Rounds. It's a pleasure to have here today Dr. Gustavo Parreira, a good friend from our partner society in Brazil, SBITE, and from Santa Casa de São Paulo, School of Medicine, one of the most traditional medical schools in Brazil. We're going to start this year with these meetings every Monday. As you have remembered, they're gonna work very hard the first semester, and then in July we're gonna have our Pan-American Trauma Society Congress with SBITE in São Paulo in Brazil. So hopefully we're gonna be able to see each other in person in a few months. So I'd like to say thank you, Dr. Gustavo Parreira, for the privilege of having you here today presenting this case, and looking forward for a great interactive meeting today. Dr. Parreira, thank you very much.
Hello, Antonio. Nice to hear you. Nice to see you. Nice to see everybody. Are you hearing me? Yeah, Doctor. Okay, so let's continue. First, I'd like to start this year with this Happy New Year for everybody. And again, thank you for the opportunity to be here presenting our case and hearing your opinion. I value so much, and I'd like to share with you good news. I was talking to our current, the president for the Brazilian Trauma Society, Dr. Mauricio Godinho, how much learning we have in this meeting. And we kind of came up with the idea in making this meeting an official part of our agenda in the Brazilian Trauma Society. And then, well, I'm very excited to tell you that we make this Monday meeting as an official part of our weekly agenda. So this means that we're going to share the link weekly with all members of the Brazilian Trauma Society and all the students of the trauma leagues. And I hope really that they can attend the meeting and learn as much as we did last year. So this year's is about 40-year-old and Brazilian Trauma Society, 40 years, and we have this Congress as the middle part in July, if I'm correct, Antonio. And certainly I hope we can see each other there. Okay, well, let me start with the case. It's very difficult to choose a case in this meeting because you put the bar so high. The cases that are presented here are so incredible. And well, we decided to bring these up because it was difficult for us to decide what to do. And well, let's see what you can help. Is it okay, Valeria? Can I go on?
Yes, doctor.
So let's do it. Again, Santa Casa is hospital in São Paulo. We are in downtown. We have an estimated 2 million population, which we are responsible for. We see kind of 2,000 trauma patients per year. 90% are blunt. Yeah, different from Flávia in Rio de Janeiro. And we have this 20 attendants here in Santa Casa. The trauma surgical team is led by Dr. Asef, who's in the meeting with us. And well, let's start with the case. It's a male, 31 years. He was a motorcycle, temporary loss of consciousness at the scene, but when the pre-hospital team arrived, he was at 110 beats per minute, respiratory 26, blood pressure 160, and Glasgow Coma Scale of 13. They have immobilized, started the oxygen by mask, granted a IV access, and went to the hospital. The primary survey showed a patient with patent areas, not more different, no different from what it's seen before. Respiratory rate of 30, decreased breath sounds. He had pain on sternum and rib cage with palpation. There was a clear flail chest. There was no external bleeding, and the patient was relatively stable. The heart rate 100, blood pressure 110/60, normal heart sounds, and good extremity perfusion. Glasgow Coma scale improved. There were no neurologic deficits, and he was isochoric. There was this hematoma in the chest wall, anterior right part, and exactly is the part where there was a paradoxical movement. We started with the restriction of cervical spine. Oxygen was kept on. 2 large bore venous to guarantee access, but of course we didn't start any kind of volume because he was relatively stable. Fast EFAS was negative, and we asked for blood tests and X-ray. This is the chest X-ray on admission. You see here, mediastinum is okay, no alterations for the diaphragm, and you see some rib fractures here, but no major alteration, no pneumothorax, hemothorax. Despite the paradoxical movement, he had no many rib fractures. Pelvis was normal, no pelvic fractures. And the secondary survey showed that no allergies, no use of medications, less meal 6 hours, and the mechanism of trauma was pretty much what we thought. He was stable and not many different things here. Blood tests arrived with a hemoglobin of 212. ABGs showed a good oxygenation, PCO2 34, base excess -3. Lactate 3 is normal, slight alterated for our normal here, and normal labs, the creatine phosphokinase of 490. Then we start with this whole body CAT scan, and I'm going to show you, and then we discussed after. We start with a normal trachea, esophagus, the vases are okay. You see no hemothorax, no pneumothorax so far, and aorta okay, aortic arch okay, no hematoma at this part, and going distally, bronchus are okay. We start to see a small hemothorax bilateral, and just small amount of blood. Here is extra pleural space. And going down, we start to see this here. I'd like to see this is the heart, of course. Is the right atrium, and pay attention, please, in this area, starting in this inferior vena cava. It is a filling defect that goes down. This is the liver, okay? This is the vena cava, and there was this filling defect here. If you go down, we found it to be here again, together with liver laceration. Let me show you the liver laceration first. So the inferior vena cava is here. There is this hematoma and laceration here with all perhaps 3 segments or more. And here you are, the complete injury in the liver. And after, together with this, we have already, I'd like to show you this. This is a small spleen laceration, grade 2. There is no great volume of blood in cavity. So I will come back again to you to show the main problem we have here. That was exactly this injury again in the retrohepatic IVC. This, in fact, at this moment was considered only a filling defect. We didn't actually say it was an injury per se. And let me show you the reports. For thorax, rib fractures, 6, 7, right side, no deviation. There was a sternal fracture, no deviation too, but explain the paradoxal movement. There was left lung contusion in small bilateral hemothorax, and the abdomen for liver large laceration, subcapsular for extending from the subcapsular area to the hilum. But there was no contrast, no pseudoaneurysm, no vascular injury, no sign of vascular injury inside liver parenchyma. For the IVC, inferior vena cava, we noticed this filling defect. It was probably associated with a thrombosis with a venous injury. There was, again, filling defect in the hepatic veins, mainly the right one, and it was probably a thrombus too. There was this spleen decline, and 3 intraperitoneal fluid, small volume. Jenny Valdez is requesting decline. Okay. And I would like to hear your opinions. Then we got this hemodynamic stable patient after 90 minutes of the trauma. We got these rib fractures, 5 and 6 with a sternal fracture. There was this lung contusion, this liver injury, grade 5, the retrohepatic, what we thought was a retrohepatic IVC injury with no contrast extravasation, but clearly with the intraluminal thrombosis, and right in the entrance of the atrium, a big thrombus there, and we are so worried about this thrombus just going to the pulmonary artery and making perhaps a sudden death even. And there was also this splenic injury. So I'd like to hear your opinions. How can we, how would you deal with this? Valeria, please, you can conduct from here.
Okay, thank you, Dr. Parreira. Dr. Kasim, your comments, please.
Good morning. This is a spectacular case to begin the year 2022 coming from Brazil. Wow. Fabulous case presentation, and Dr. Parreira summarized it very succinctly, and we got to see everything that needs to be seen, and then process it in our mind what we would be doing in a case like this. So let's take step by step. This is a 2-cavity injury, one in the chest, one in the abdomen, and both related to multiple rib fractures. And the magnitude of the trauma must be enormous, because he not only has rib fractures, but he also has a sternal fracture. That means he must have had a tremendous blow to the right side. And underneath those fractured ribs are vascular organs such as spleen, liver, and they both have sustained some injury as well. Surprisingly, he is quite stable when he comes to the hospital, and Dr. Parreira and his team do a methodical evaluation of the patient to see what needs to be seen and how they can address and the pattern of injury and what they need to do with it. So the way I'm looking at it is that he has multiple rib fracture with lung contusion. That at this moment does not require any treatment, although he has a small amount of hemothorax. Fortunately, he doesn't seem to have a pneumothorax, but I would very carefully look for the pneumothorax, because they usually go hand in hand. Be as it may, if I'm inclined, I probably would like to put a chest tube in, but it is not my priority at this moment, because I would like to get rid of that blood in the right chest cavity. So, having seen the shadow or filling defect in the IVC, but not any extravasation of fluid, I take it that this was contrast enhanced CT, and I have to assume this is an extension of the thrombus originating in the right hepatic vein. And when the right hepatic vein drains into the IVC and the clot is just propagating into the IVC. Like Dr. Parreira has mentioned, this does have a potential for getting dislodged from the area of the IVC and go to his pulmonary vasculature and then give rise to pulmonary embolism, which could be dangerous and maybe life-threatening as well. So, because he is stable at this moment, and I think I would like to continue observing to see if there is any greater volume loss in the peritoneal cavity, either from the liver injury or the minor splenic laceration. But I think my mind probably is on that clot which is sitting in the IVC. What is going to happen to that? And if I have the luxury and the cooperation of the interventionalist, radiologist, vascular surgeon, I might want to get a venogram on this, and it'll be quite easy to get a venogram to put a needle into the femoral vein and shoot some dye to see what I'm seeing as far as the morphology of the IVC is concerned, to see if it leaks, if there is any leak from the IVC itself, or is it just clot sitting there. And then I probably would like to think about how am I going to prevent a possible, not inevitable, possible minor or massive pulmonary embolism from which the patient could die. So that's what I'm thinking. I will stop there and let other professors like Dr. Holman chime in to see what he would be doing. Thank you.
Thank you, Dr. Kasim. Dr. Antrak? Dr. Holman had to go to the
yes.
Thank you.
Yes, so I was concerned on a few of the slices. It seems like the filling defect in the IVC is contiguous with the liver laceration. So I think there's a reasonable likelihood that there's a disruption of the inferior vena cava into the liver, and currently it's clotted off, so the patient's stable. And then you have, as Dr. Parreira and Dr. Kasim mentioned, there's the potential for embolization in a clot that's too proximal to put an IVC filter. So, as long as the patient's stable, I guess you can observe him very closely, but plan to go back with a low threshold, or to take the patient with a low threshold to the operating room if he becomes tachycardic or at all unstable. And I would plan to approach it with a right thoracic abdominal incision that would give very good exposure to the IVC at that location and the hepatic veins. It's the approach that I believe Dr. Supa mentioned in another case where there was active bleeding from the retrohepatic IVC and hepatic veins. I think that would very nicely expose that area, allow evacuation, control of the IVC, approximately distally evacuation of the clot, and repair of the injury. Although I think for now, cautiously observe, but with a very low threshold to take him right to the operating room for that exposure.
Thank you, Dr. Antrak. Dr. Colette?
I agree with all comments, but I think these patients have a very big problem, because you have injuries in the retrohepatic vena cava and liver injuries beside it, very, very near of the liver. Maybe become that, I think, as Dr. says, that these injuries may be by the liver. The injuries of the vena cava is in the liver. So it's a very, very difficult problem. You have a clot in the vena cava. You have sometimes to take this clots out. So it's very difficult to use some anti-aggregation or anticoagulation in this patient at this moment. So I think this patient is stable. You can observe. If you cannot, if the patient become unstable, you can go to try to treat it. So I think in this patient, you have to approach the vena cava and to take off the clots and try to suture the vena cava. That may be a very, very difficult maneuvers to do this. You can use, as Dr. Cassim says, it's very important to see venography. If you can see a venography, you can see where is the injuries more, or the reconstruction of the CT, but the venography is more specific for see where is the injuries of the vena cava. So you can, in this with this, you can maybe program the surgery if you need. You can put a stent seen in the retrohepatic vena cava, not near of the venous hepatic veins. Very difficult to put this in this situation sometimes. So I think this patient at this moment may become more safe. It is observe this patient and not go to the surgery immediately. If this patient go to the surgery, you need to very very big problem. That's it.
Thank you, Dr. Collet. Dr. Nedelkovic, can you hear us?
This is a very difficult case, and I'm not sure exactly what the right thing to do is here. Honestly, I would definitely, put an A-line. I would definitely take this patient to the interventional radiology. It's a grade 5 liver laceration. I would interrogate not just the vein and do a venogram. I would also ask them to shoot the arterial system as well. I would also like to check this patient's LFTs because I have a feeling that not only vessels are injured and with clot in the IBC, but also he's dumping bile in the cava too, because probably the bile ducts are injured as well, since there's no fluid around the liver or intraperitoneal on the CT scan. So I'll definitely check that. With regards to the approach here, I know I would definitely reach out to a transplant surgeon and the liver transplant guys. We have a good team here. I would definitely reach out to them if this patient would come to my facility and discuss options. I know there have been instances in the past in the literature where actually, the liver was kind of taken off and the cava repaired and re-implanted. So this may be a case that would need that. And that's all I have for now. Thank you.
Thank you, Doctor. We have Dr. Stubing. Dr. Stubing, would you like to make any comments?
Yeah.
Okay.
Thank you. We're over here in Malawi where all of this is kind of a dream. Even just getting a CT scan. I agree with all the comments. That is a terrifying looking clot, and I think that if that clot breaks loose, you're not going to even have time to go to the operating room. But that doesn't really answer the question of what to do about it. I do like the idea of asking interventional radiology to see if there's any kind of removal options they have, or if there's space to put a suprahepatic cable filter through the IJ. It doesn't look like there's enough room for that, but I'd want to try to prevent that clot from moving. I don't think anticoagulation is going to be safe at all since it's a grade 5 liver injury, and definitely agree with calling the transplant surgeons for help operatively, since they operate on this kind of thing a lot more than probably any trauma surgeon. So that's my input.
Thank you, Dr. Steven. Dr. Parreira, we go back to you.
Yeah, are you listening to me? I'd like just to put there, we have a very experienced vascular and trauma surgeon here with us, Dr. Góes from Pará. is the north of our country. I'm not sure. He wrote down his ideas here. I don't know if Adenar wants to participate, and he has a lot of experience, not only in open vascular trauma, but also as an interventional surgeon. Adenar, can you hear? Can you open your mic and perhaps say some words?
Hi, Parreira, do you hear me?
Yes, clearly.
Yeah, I am in the OR right now, waiting for an amputation trauma case, so I can be called any moment. So it's difficult for me to participate, but I think anticoagulation is not an option for at least 48 hours due to the associated liver and spleen injuries. So it's not an option. And if I have endovascular radiology resources, I would do a venogram and study the extension of the thrombus. And if available, I would perform a mechanical thrombectomy and probably build IVC temporary filter above the renal veins because of the potential of pulmonary embolism. These are my main thoughts. And of course, if available, I would also do an angiogram of the spleen and the liver and see if I can embolize anything there, also in the arterial section.
Okay, thank you. Well, let me show you first point here that was raised already. We just don't know if we did right or wrong. I don't think there is a clear answer for this case. The fact is we call everybody, we call vascular, we call thoracic surgeons, and we together figure out how to do it. So let me try to show you how we thought. First point, that anticoagulation was not an option because of the hemothorax, the rib fractures, and spleen. If you should anticoagulate this patient, probably he would have high chance to bleed from the liver and from the spleen. And everybody would say, well, let's take the spleen out, let's operate, do an splenectomy and anticoagulating sequence. And probably if you try to do this, our major problem here, as said by Dr. Colette already, and this is that there is a serious vena cava injury. You don't know where it's going to lead you. And probably I've seen cases of a total hepatectomy trying to approach blunt inferior vena cava injury at this region. So you can control the bleeding by a shunt or extracorporeal circulation, but you end up not having how to correct the vein. And this made us try to observe the patient. That's what usually say, the simple is the best, isn't it? So we try to hold our horses. Anticoagulation not before 48 hours. We're going to repeat the CAT scan. We got as many brains together to decide what to do. Of course, the trauma surgeon is the responsible for the final choice, final decision. We also do echocardiogram because of the magnitude of the trauma. Perhaps you could have a cardiac injury. Turns out echocardiogram is normal. He remains relatively stable. The basic SS was from 2 for -4 during the next 36 hours. There is a slight drop in hematocrit. I would say it's expected drop, and not so much. There was a moderate pain in the chest. This was something that we worried about because we had to have someone really breathing well. Otherwise, we had to intubate and control the oxygenation in other way. The abdomen showed a slight distension with no peritonitis. And well, Dr. Cassim, here are after 36 hours, our X-ray, as you said, increased hemothorax bilaterally, and we went to the CAT scan to show. Let me show what happened after 36 hours. We had really a clear increase in the volume of the hemothorax bilaterally. Let's do it together. again, see there is also increase in the volume of the intra-abdominal, intraperitoneal fluid. So the hemothorax increased and the hemoperitoneum increased too. The image in the inferior vena cava going to the atrium, I personally thought that it would get worse, but was not a consensus. See again the image. I'm going to let it go per se. Start here again. See there are the thrombus, and this is our arterial phase, so we're not going to see the vein right now. I chose this phase because you're going to see the spleen, and look what they found out in the spleen to complicate our case a little more, make it more difficult. So we have a clear pseudoaneurysm in the spleen with an increase in the abdominal fluid. And with this, there was no another finding in liver injury. So the liver injury was quite stable, and we had this increase in the volume and a clear pseudoaneurysm in the spleen. Let me go ahead. So discussion 2, we get this hematocrit dropping, bilateral volume increase in hemothorax, the thrombus in IVC was stable, and we had a pseudoaneurysm in the spleen. And then again, we had to decide if we would observe the patient, try to angioembolize it, or go to splenectomy. And I'd like to hear your opinion here. Valeria, please, can you ask the participants? Thank you very much.
Sure, Doctor. Dr. Colette, would you like to make a comment?
I agree. I think these patients, maybe if patients is stable, you have fluid in the chest, fluid in the abdomen, immense the fluids, maybe it's blood, maybe blood with fluids. Oh, so in these situations, I think these patients need to put a chest tube to drainage the hemothorax or the pleural effusion bilaterally, because it's maybe compromises next time the pulmonary function. On the abdomen, you can see a blush in the spleen. So if the patient continues stable, I think this patient needs to go at this moment to go angiography, and maybe I think these patients need to make arteriography of the liver and the spleen, and these patients need to make a venography to see what's happened in the vena cava, and try sometimes to put some endovascular treatment in the vena cava or not, or maybe surgical, try to make a surgery in this patient. Sometimes I have thinking about maybe these patients with very big liver injuries, maybe come to call the liver transplantation, to make a liver transplantation, acute liver transplantation. You have 2 steps you can do. First, you can take the liver out of patient, control the patient, take the liver out and treat the liver in the table. And then put again the liver in the patient. Is one possibility in this situation. The second possibility, you can take this patient without the liver and call to an emergency liver transplantation. I have called some people in my service about this. Dr. Carneiro sometimes have told me to call him early when I think about this possibility, because sometimes very, very difficult to put the patients to call a new liver for these patients acutely. You have around 24 hours to find a liver and put a new liver in this patient. So I think it's very important in this patient for treat this first, it may be an angiography and sometimes some endovascular procedures in this patient. And sometimes I need a venography to study the vena cava, heterohepatic vena cava, to see what about we can do with this patient. That's it.
Thank you, Dr. Dr. Kasim, would you like to make a comment?
Okay, so now that it's past 36 hours and he's relatively stable, little drop in hemoglobin, but nothing to write home and tell my mom about. I need to enumerate what is causing the patient's problem at this moment and how can I approach this methodically. So we have three things to look at. One is the slight increase in the hemothorax, very easily treatable with a chest tube, and moderate increase in the abdominal collection. And my guess is it is probably related to the splenic injury with the formation of a pseudoaneurysm. And the third thing is the clot in the IVC has not really increased very much, but difficult to tell at this moment. And the liver injury seems to be stable. Now you're looking at 36 hours. So what I would like to do to this stable patient is take him to the operating room, put a chest tube in and the sterile condition, and have the angio people do a clot, angio embolization of the pseudoaneurysm. And also, if at all possible, I would like to float a Fogarty catheter through the IVC to the juxtaposition of the IVC just before it enters into the right ventricle, and have a little balloon there as an insurance that he will not throw a big clot and cause death and demise. A small clot, he can tolerate it, but big clot, he may not be able to. Something that I would be thinking about if I could do that. So mainly, I would be concentrating on the help from the angio people to see if they can embolize the pseudoaneurysm, chest tube drain, and watchful waiting of what the liver injury is going to show for the next 48 hours. That would be my plan. I am reluctant to take this patient to the operating room to do a big incision because I'm afraid he's stable and I can't make him, I'm afraid that I could make him worse.
Exactly.
Those are the thoughts I have. Thank you.
Exactly my thoughts too, Dr. Kasim. Valeria, Dr. Rezende Neto from Toronto is trying to speak. I'm not sure he can open his mic too.
I just invited him to talk, yes. Yes.
Yeah.
Oh, hi, thank you very much, Valeria. A very interesting case, Parreira. So my question to you first was regarding the liver function test, because one of the worrisome findings is if this patient's liver is actually dying from the injury to the vena cava, and you also mentioned that there are some portal venous thrombus as well. So, but you already mentioned that it's not very significant, the increase in the liver in the hepatic enzyme. So that's a good thing. And I think that what this patient is doing for you there is to have the best liver tamponade that you can get, right? So the liver is not bleeding. It seems that there is no biliary leak, which is a good thing. And the patient is remaining stable. So for the splenic pseudoaneurysm, what I'll do is embolize that. And like Dr. Collet and Dr. Kasim and others have mentioned, we need to kind of study this patient's vena cava with contrast just to make sure that things are going well. And I would put an IVC filter above the vena cava so that we can protect this patient from an embolic event. So most likely this is like the best that you can ask for after a retrohepatic vena cava injury, where the patient remains stable and you have all these percutaneous non-invasive options to do this. So I would not operate on this patient right now. Thank you.
Thank you, Joan. Of course, you have lots of experience in this, and I've seen your publication on the for balloon hepatic exclusion on the Pan-American Trauma Journal. But here, what happened is that our vascular surgeons were involved in the case from the beginning. And the idea, they have a lot of experience in these IVC filters for preventing pulmonary embolism. But the problem is that the thrombus was in the atrium. The thrombus is getting into the atrium. So the only way to take this out was extracorporeal approach, extracorporeal circulation with open cardiac surgery. So we got the vascular and the cardiac surgeon together, and they come up with this idea. Should we do a major surgery like this, considering that we might end up with a total hepatectomy and perhaps an outer transplantation? So it became so complicated to indicate such a procedure. But all these things were really discussed with the cardiac and vascular surgeons. Thank you.
Thank you, Dr. Parreira. Dr. Antrak, would you like to make any comment?
Sure. Yeah, I agree that I would also avoid operating at this point simply because to operate on the spleen, it might dislodge the clot or stir up, destabilize the vena cava injury and turn a stable patient into an emergency. But he does have a very significant drop in the hemoglobin from 12 to 9, so 25%, likely from the spleen, where he has a big increase in the hemoperitoneum. So I agree that I think probably it's best to consult the interventional radiologist, see about embolizing the pseudoaneurysm, put the 2 chest tubes in. And the interventional radiologists have a lot of ways to deal. They have a lot of tricks now that are new. When they operate on the carotid, they put umbrella filters, temporary ones proximally, or they can put a balloon proximally in reverse flow to prevent embolization. So I would see what they have to offer. I wouldn't myself put an IVC filter in because the clot is just too high and it's bound to create complications. But the interventional radiologist might have ways to deal with this, even putting a stent in to get control of the bleeding, or if they try to remove the clot, they may have ways to rapidly get proximal and distal control of the IVC to stop the bleeding, while they or the surgeons can consider a repair either interventionally or in the operating room.
Okay.
Okay, thank you, Dr. Antrak. We have Dr. Ochman. Dr. Ochman, would you like to make any comments?
No, we can see you.
I cannot. Okay.
Yes.
You always say that a true surgeon doesn't know what he's talking about, but has an opinion. That will be me now. I missed part of the presentation. Based on what I see now, I agree that I would embolize the spleen and probably do nothing with the liver and surgically. I will just anticoagulate the patient because the risk of a surgery is too high and the guy is doing okay. So his liver took a beating, but it's still viable. INR was normal in one of the, was mentioned on the chart. So that's all I will do right now. But again, I don't know all the details. So thank you.
Thank you, Dr. Anshak. Dr. Lenin, would you like to make a comment?
Yeah, I mean, I think I agree with everyone. It's a very difficult case here. But I would embolize the spleen and see what they can do about placing a filter there, but I'm not sure they're going to be able to do it.
Okay.
Thank you, Dr. Lenin. Okay, Dr. Parreira, would you like to continue?
Okay, let's go. We went to the bilateral thorax drainage. Discussion was exactly as the comments that were made. We discussed about the venography, and there are people who wanted to do, but in fact, it wouldn't change our approach. So we decided to keep his renal function, not administering more contrasts. And no, doing it for the splenic angioembolization. We did this, you see the selective catheterization. For here you see the pseudoaneurysm, and after a while, it got really bleeding from these injuries, clearly seen in this another shot. Let me show you how they did. Here is the pseudoaneurysm, and they use these microcoil EV3. This is a distal embolization, yeah, not a proximal as we used to do, but they decided to do this because of technical ideas. We proceeded with the drainage, the thoracic area. Let me show you the paradoxical movement as I was telling you from the beginning. We got this after drainage, immediate after drainage X-ray. This one right one was not very well, but it was working. We kind of kept in. The rest one here is more like a lung contusion than blood. So after 48 hours, we started like 12 to 24 hours after the embolization. We started the unfractionated heparin IV continuously. The guy kept stable with no metabolic acidosis and no fever as we embolized the spleen, no fever, no clear signs of infection. And 4 days after this drainage, we kind of noticed a worsening in left side, even with the drain working. So we got the patient again in the ICU, in the CAT scan. And we noticed that the drain was badly located. So it's totally out of the area where we found fluid. The other alterations are the thrombus was quite stable. There was not a big difference. Let me show just for curiosity. This is the right drain show. Yeah, see, it's practically inside the atrium. Go ahead. And here is the normal part. Continuing with the CAT scan. The liver injury. You can see it better right now in this picture. And we got good images here again. Let me show you the coronal and sagittal views. Here you can see it very well. I don't know who used the expression, but it's a scary thrombus, terrifying thrombus image. Let's go ahead and show you what happened. So we got two more discussions, but we are almost on time. And in fact, I'll just skip this one. We went to the video thoracostomy, video assisted thoracic surgery, we call VATS, with repositioning the drain. We suspended the anticoagulation for 24 hours. This is after the operation, much better. Resumes and fractionated heparin, no more hematocrit drops. The remain hemodynamic stable with efficient pain control, no fever, and well, left side worsens. I will skip this CAT scan because let me show. So after 12 days of the thoracoscopy, we were able to discharge the patient home, and there was this discussion. Should we anticoagulate it for how long? What is the duration? And what type of anticoagulation? Would you like to comment? I don't know. Let me finalize the case with the evolution because we don't have much time left. We kind of decided to keep close monitoring in the vascular clinics. We chose enoxaparin 1 milligram per kilogram twice a day, and was the first thing. And 18 months later, this is the CAT scan this patient have. Please take a look at it, and there is not a scar of it. No, we found no thrombus, no signs of hypertension, and obstruction of hepatic veins. Let me show you again here, so you won't believe me. Take a look at this. So take a look at these three veins, left, middle, and right veins, perfectly open with no obstruction. You can see no scar in the liver. You see the coil here in the spleen. Yeah, and this guy went very well. So when we brought this case, we are not saying that this is the right thing to do. I think we were we had luck. We were lucky in this, making the decisions together, and this patient went very well. I confess, I prayed a lot. He's a young guy, has 2 children, small children, and every day I was talking to him, totally conscious, mental status is normal. I prayed a lot for this thrombus not to go to the pulmonary artery. So let's see your comment, final comments.
Thank you, Dr. Parreira. Dr. Colette, would you like to comment?
Yeah, Parreira is a very great case, very interesting case. In this case, we have a message. Sometimes we have stable patients with a blunt trauma, and when we make a image exam, you show a very devastating injury, but this injury is stable. So if you go to make a surgery in this situation, or put this patient in a surgery, because the hemodynamic stability of the patient, the clinical signs of the patients is normal. In these situations, maybe observe the patients. Sometimes these big injuries, when you put in the patient in the OR, you may be a very devastating surgery, and maybe some of the patients don't live. I have another case like this, and I can show, but it's very important to think about. The image exam sometimes is not very, very important to make a decision to make a surgery, but they may be, sometimes they may make decisions to observe near the patient, very, very near, and you can have sometimes this situation. I know that heterohepatic vena cava is very, very difficult to approach. And sometimes if this injury is blockade, not blending to the cavity of the pleural cavity or the abdominal cavity through the liver, you can observe the patient and not make a surgery in this situation. Congratulations for the presentation. It's very, very important case to discuss, and maybe sometimes injuries of the inferior vena cava or hepatic vena cava can be more diagnosis in the using of angio-CT in the patients on the blunt trauma. Thank you, Parreira.
Thank you, Dr.
Welcome, my friend. Thank you.
Dr. Kasim, would you like to add any final comment?
Yes, I'm going to keep it simple because I need to go. So, Dr. Parreira, the difference between a good surgeon and a great surgeon works methodically like you have done. What a wonderful presentation to start the new year. Fabulously managed case. Thank you so much for educating us.
Thank you, Dr. Cassim. We educate ourselves here. This meeting is fantastic.
Thank you, Dr. Kasim. Dr. Antrak, any comments?
Yes, so you mentioned luck, Dr. Parreira, but I think if there was any luck involved, it was on the part of the patient who was lucky enough to have had such an excellent group of surgeons. You really superb clinical judgment. You exercised appropriate restraint. You consulted a large group of experts to consider the best option, and I think the outcome was superb. And I hope that the patient learned a lot from his experience, and for the sake of his children has given up on the motorcycle. Maybe you can tell us if did he come to see you on the motorcycle after 18 months? I hope not. Maybe he's taken the bus or a taxi or Uber or gotten a car, but you know, really pretty dangerous.
Thank you.
Thank you, Dr. Antrak. Dr. Ochman, would you like to make a comment?
Sure. Dr. Umtrach, if that would be my patient, I'm sure he will come with a motorcycle. But no, I want to congratulate you, Dr. Parreira. This was, in my opinion, perfectly managed. I would not have done anything different, and this guy is alive because you kept a cool head and didn't rush to try to fix everything. This is a retrohepatic IVC injury, the lethality.
Thank you, Dr. Lekovich. Dr. Stubin, would you like to make any final comment?
Same as everyone said, really interesting. I think that image of the clot going into the atrium will keep me up tonight, even though the case is resolved. But it's great to learn from all of you, especially when we're in a much more resource-poor setting. So thank you.
Thank you, Doctor. And the last, Dr. Joao Resende Neto, would you like to make any comments?
Oh, thank you very much, Valeria. So, Parreira, that's a very interesting case. And like Dr. Kasim said, a fine surgeon needs to know when not to operate. And I'll just add a little bit here, Dr. Linin. In Brazil, we say you don't poke the jaguar, not the bear, because we don't have bears there. So.
Great comment. Great comment.
Thank you very much. Congratulations. Beautiful case. You got to publish this, man.
Thank you, João. We are in process of it.
Thank you. Thank you. Okay, Dr. Martes, would you like to make any final comments?
Before the present, let me just add that we here have many Brazilian trauma surgeons in the meeting today. This is because of this 40-year initiative of putting this. So this meeting is an official meeting for the Brazilian Trauma Society today, and I'm very, very happy to have all the trauma surgeons here to learning from you all. Thank you.
Yeah, so another great meeting to see. You have people join from the Americas, from Africa, from Iraq, from multiple places. That's the goal of this meeting that has been happening for almost 12 years now. We had another great presentation by Dr. Parreira. That's the goal of this meeting, to see how we treat the same patient in multiple places in the world. As you can see, Dr. Beth Stublin said you not have all this technology at her hospital, but for sure to treat this patient and to try to save this patient with the tools that she has. So that's the idea of this meeting. Remember, if you want a certificate, please join, check the chat. There's a code for CME. Even if you're not in the United States, you don't need a CME code, but you can print a certificate of CME. You can have a certificate of participation for this meeting from anyone in Americas or in the globe, okay? Like Dr. Parreira said, SBITE's new board is being very active and going to have a great year with SBITE and work together for the Congress, for American Trauma Congress, SBITE Congress in July. But I really stimulate all of you to talk to your local society for the Americas, to invite medical students, residents, other physician staff to join these meetings. Like we had like more than 77 people today. These meetings keep growing, and I keep saying for 12 years, we all learn with each other every Monday. Thank you, Dr. Parreira. I would like to invite all of you to talk to Valeria to schedule your case. You need to start to create the agenda for the next few months. Please talk to her, present your case. Please stimulate your residents to present some good case also. Dr. Parreira, you have the final words to end this meeting today. And thank you for Santa Casa de São Paulo, for SBITE, Dr. Cesar Sef, for another great presentation. Parreira.
Antonio, I just like to acknowledge that you believe in it from the beginning. You were here from how many years doing the presentation? Many years before. So thank you. We own these to you. Thank you, man.
Thank you all. See you all next Monday. Take care. Happy New Year.